Well, good morning, everyone, and welcome to Medical Grand Rounds. I'm Dr. Laura Lacher, and it's so delightful to see faces back here in the room at Southern Auditorium at Providence St. Vincent. As usual, we'll go ahead and get started with some reminders and logistics, and then introductions for today's speaker. Please be sure to join us next week here in person, Tuesday at 8 a.m. in Southern Auditorium at Providence St. Vincent to hear and learn and perhaps be a bit entertained from Dr. Alex Schaefer, who will be presenting Thieves Market, a fun and interactive case presentations. Grand Rounds is a joint effort between Providence Portland and Providence St. Vincent. We are always available on Tuesday mornings on Teams Live. We are often here in the room at St. Vincent at 8 a.m. and we are sometimes live at Providence Portland at noon on Tuesdays. You can earn CME credit by watching live virtual on Teams, by being live in the room, or by watching a recording of the event. Each week, the Grand Rounds invite lets you know where we will be, and the same link also works for the video. I'll be holding the Q&A to the end of today's session to ask as time permits, but please go ahead and post any comments or any questions for those of you who are out there online. And now to introduce Dr. Alifia Rajabali. She is a practicing physiology cardiologist at Providence St. Vincent. She completed residency at Mass General Hospital and then cardiology fellowship at the Beth Israel, followed by fellowship in electrophysiology at UCSF. Dr. Rajabali is director of the Heart and Vascular Institute's Cardiac Device Clinic. Her passions include all things EP, SVT, AF, VT, and conduction system pacing. Dr. Rajabali, I am so glad that you are all over that alphabet soup and are here to teach us and help us today. Thanks so much for presenting.
Hi, everyone. Thanks so much for inviting me today. I'm actually really excited to give this talk. So we're going to get right to it. We're going to talk about atrial fibrillation. Rate versus rhythm control is the title of my talk. But today's learning objectives are going to go hopefully a little bit beyond that. So we'll review the appropriate considerations for rate versus rhythm control. We'll also take a look at the practice-changing updates to the 2023 AFib guidelines and identify risk factors for management of atrial fibrillation. So I want to talk a little bit about the natural history of atrial fibrillation because I think this is going to sort of become the cornerstone of the next couple of slides. So AFib typically presents with paroxysmal episodes, so episodes that are brief, usually terminating within 24 hours, definitely less than 7 days. And that's when my slide sort of says, we'd consider rhythm control. That will then, in many, if not most patients, there'll be a transition then to persistent atrial fibrillation. In fact, there's about a 7% per year progression from paroxysmal to persistent. And the reason for that is during atrial fibrillation, there can be electrical and structural remodeling of the atria. And these alterations then lead to a situation where AFib begets more AFib. And then you go on to persistent AFib. And I would recommend attempting rhythm control in these patients. And then you go on to what we call long-standing persistent atrial fibrillation. So that's AFib for more than a year's duration, generally speaking. Now, long-standing persistent AFib for years can preclude restoration and maintenance of sinus rhythm. Whether it's with ablation or antiarrhythmic therapy, it's just difficult to reverse disease when you get to that stage. So, and then of course you progress on to something called permanent AFib. So permanent is not a time frame, it's a discussion between the clinician and the patient, the physician and the patient, that at this point, we're not going to institute any rhythm control strategies. We're just going to leave you in atrial fibrillation, and that's permanent. So when you first evaluate a patient, it may seem that a patient doesn't need to be in sinus rhythm that much. So they have short episodes of AFib, they're minimally symptomatic, their AFib just isn't a big deal. But what I want you to keep in mind is that when they're in AFib for longer and longer periods of time, because that is the natural progression of the disease, they may develop symptoms. And they may develop changes in cardiac function over time that would then favor a rhythm control strategy. So think of sinus rhythm or maintaining sinus rhythm as kind of a bridge to the future for this patient when he may develop changes in cardiac function or changes in symptoms. So no talk on AFib is ever complete without presenting this trial. I'm going to take you back in time now. We're going to go back 20 years. This is when this paper came out in 2002, and it's, the all popular AFFIRM trial. So this was a comparison of rate versus rhythm control, and this is the paper that then sort of started the conversation of considering rate control. In this paper, they randomized 4,000 patients to rate versus rhythm control and followed them for 5 years. The endpoint was mortality. Spoiler alert, there's no difference in mortality and rate versus rhythm control in this paper. And the take-home message was there are potential advantages of rate control, such as a lower risk of adverse drug effects, and really, pursue rhythm control for symptoms. So that was kind of the idea behind this. Now let's look at how they actually achieved rhythm control. So I put here the list of medications that they used for rhythm control, and you can see highlighted in red that amiodarone was one of the most commonly used drugs. This is not a first-line antiarrhythmic drug. We know that. It's actually our antiarrhythmic drug of last resort. And some of the other medicines, so let's just look at them. Disopyramide, I don't think I've ever really used that for AFib. Morsazine, I've never prescribed that. Quinidine, we don't use that for atrial fibrillation. So the point is, a lot of these antiarrhythmics are outdated. Electrophysiology does not prescribe them. We don't consider them first or even second line for management of atrial fibrillation. And then how many people got catheter ablation? Because there's no mention of that here. 14 people got catheter ablation because catheter ablation was just coming out when this study was published. So now let's look at, so we're really randomizing here to rhythm control with antiarrhythmics. So let's look at how good are antiarrhythmics over time. So this paper came out in 2005 and essentially told us that antiarrhythmics have weaning efficacy over time. So they looked at the likelihood of staying in sinus rhythm for 3 years. And in 3 years, only 50% of patients on amiodarone stayed in normal rhythm. Now that's the most effective antiarrhythmic that we have. So it's not surprising that there's no differences in AFFIRM because the drugs were just not effective at keeping patients in sinus rhythm. AFFIRM also only followed patients for 5 years. We now know that patients can develop symptoms of after being in AF for several years. And so while acutely they may not seem as symptomatic and rate control might seem fine at the time, over long-term follow-up, there are changes in cardiac function and sort of exertional tolerance and overall ability. So I'm now going to fast forward to the modern era. And this is a paper from 2020 that was also designed to look at rate versus rhythm control. The caveat, though, here was that they looked at early rhythm control to see if there was a benefit from rhythm control. So what does early rhythm control mean? It means AF less than a year in duration and up to 36 days from diagnosis to enrollment. So these people got in early. So in East AFNet 4, they looked at about 2,800 patients over 75 with early AF, and they randomized them to catheter ablation and antiarrhythmic drug, or usual care, which is just rate control. And they did a 5-year follow-up. And you can see on the curve that early rhythm control was associated with a significant decrease in the primary outcome of stroke, heart failure, hospitalization, and death. And there were no significant differences between the two groups with respect to the primary safety outcome. That's because we're using safer antiarrhythmics and where catheter ablation has gotten safer over the years. Now, there's a specific population in which rhythm control becomes especially relevant, and that's the heart failure population. We know that atrial fibrillation can cause heart failure even when it's rate controlled. And we know that there's a correlation between patients who have AFib and develop heart failure, or patients with heart failure who then present with atrial fibrillation. But one thing is clear, that AFib in patients with congestive heart failure is associated with worsening heart failure, stroke, and mortality, as well as hospital readmissions. So then this paper came out, CASTLE-AF. So this looked at about 400 patients were enrolled and randomized to ablation versus medical therapy. And in this group, medical therapy was basically rate control. Only a small percentage of them were getting rhythm control. And then ablation was obviously AFib ablation. And the patients were paroxysmal or persistent. They'd failed prior antiarrhythmic drugs, and their ejection fraction was less than 35%. So these are patients that are sick that we're now talking about taking to a procedure. The primary endpoint was death or hospitalization for worsening heart failure, and you can see clearly it was significantly lower in the ablation group with a hazard ratio of 0.62. And they also found in their secondary endpoints that catheter ablation reduced the overall burden of AFib, increased the distance walked in 6 minutes, and improved the LV ejection fraction. So I think this paper really frames the way we think of atrial fibrillation and congestive heart failure patients. We're more aggressive about offering intervention early, and we're more aggressive about offering ablation early. This is just a really fun trial that I like to mention, camera MRI. So this was a study of catheter ablation versus medical rate control in AFib in patients with systolic dysfunction. It's a small paper. They enrolled only 68 patients. And they took patients who had persistent AFib and cardiomyopathy that was unexplained, meaning they didn't really have coronary artery disease. We didn't really understand why their ejection fraction was less than 45% on an MRI. Maybe this is like AFib related or tachy mediated. And what they found was that in the arm, the trial showed that the left ventricular ejection fraction normalized in 58% of patients in the ablation arm compared to only 9% of patients in the control group. And ablation was, and then also they were looking at presence of LGE, which is fibrosis in the ventricle. And they found that the absence of fibrosis in the ventricle correlated most with the improvement in ejection fraction, and and those patients had the highest likelihood of ejection fraction becoming normalized. So if your AF has progressed to the point of fibrosis, whether it's in the LV or in the LA, you're just not going to do as well. So act early. So then this kind of laid the framework for the idea of, well, how sick is too sick then? We're taking patients with low EF who failed antiarrhythmic drugs, who have bad heart failure. So at what point do we say maybe this population is just too sick and we should just leave them on try rhythm control or just try rate control? So the CASLAF investigators came out with this paper. This is from 2023. So they took it one step further and they looked at catheter ablation in end-stage heart failure. And this was a single center study done in Germany of patients that were referred to that center for transplant and also had atrial fibrillation. So this is a large center that essentially does about 100 transplants, heart transplants a year. The primary endpoint was a composite of death from any cause, implantation of an LVAD, or urgent heart transplantation. They took about 200 patients, or randomized 1-to-1 AF ablation versus rhythm control, because we know rate control is outdated. And their ejection fraction was less than 35. They had NYHA class greater than 2. In fact, 2/3 of them were NYHA class 3 and 4, so definitely sicker. And all of them had a device with monitoring capability just so they could see if the AFib burden had decreased. They did exclude some really sick people, like their left atrial diameter is just gigantic, so greater than 6 millimeters. They've had previous AFib ablation, meaning that their substrate's probably a little bit different. Those that were urgently listed as transplant, obviously they didn't do this. And those that were on hemodialysis, which is a sicker population. And in the rhythm control arm, 50% of them were on amiodarone. The average 6-minute walk distance in this group that was studied was only 300 yards. And so what you can see here was that the results were in favor of ablation therapy. Their primary endpoint was a composite endpoint, but it was actually mainly driven by death from any cause. So that's why I put that up here. And the thought is, so why did the patients with ablation do better compared to the medical therapy group? Likely because there was an improvement in ejection fraction. The trial quotes about an 8% improvement in ejection fraction and a decrease in AF burden. And maybe it was the combination of both of that that led to an overall improvement in the ablation group. The other important thing that it talks about, and we'll get into this in a little bit more detail, is that not only did they see that patients had a bit better of an ejection fraction and were walking further and feeling a little better and having less heart failure, but there was actually AF regression. So if you look at the arrows that I have up there, I can figure out where this here. So you can see that in the ablation group, 69 patients were actually persistent before the ablation, and then after the ablation, only 35 were persistent. The rest had become paroxysmal. But in the medical therapy group, meaning pretty much amiodarone, 66 were persistent, and only 59 group, whereas in the ablation group, there was a change in numbers. So while the AF didn't go away, it became lower burden and shorter episodes. And also actually amiodarone use, that's also on this slide, decreased as well. So the amiodarone use went from 49% to 29% in the patients with AFib ablation. So they needed less drug to stay in normal rhythm as well. So talking a little bit now, we've talked about rhythm control and how the cornerstone of rhythm control is ablation. I'm just going to briefly talk about the ablation strategies, and this is only relevant because ablation outcomes are different depending on your stage of disease. So paroxysmal AFib, the trigger for this is usually the pulmonary veins. 90% of the time, you need to isolate the pulmonary veins and patients will do well. So this is a picture that just shows you the left atrium. And then these are the veins, 1, 2, 3, 4. And then these little dots are the radiofrequency ablation lesions where we've electrically isolated the pulmonary veins, which are giving off AFib from the antrum of the atrium, which is now going to be in sinus rhythm. And for PVI, for paroxysmal AF, the success rate is about 60 to 80% off of antiarrhythmic drugs 1 to 3 years after the procedure. And we'll talk about what success rate means in a second. For persistent atrial fibrillation, what is the strategy for ablation? Depends who you ask. There's a lot of variability in the way we approach persistent AFib. What we know is that pulmonary vein isolation is not going to necessarily just be enough. These patients have non-pulmonary vein triggers, and so there's been a lot of study on kind of doing lines in the atrium, like a mitral line, a roof line, isolating the posterior wall, doing a vein of Marshall ethanol ablation. And ultimately, we need a little bit more data on this. But the point that I'm trying to make here is that ablation outcome is just not as good with persistent. So you're better off referring early and dealing with this sooner, especially when we know that ablation can actually retard some of the disease progression. And so then that brings me to like success, because none of the numbers on those slides are inspiring a lot of confidence in terms of how long you can stay in AFib. So the way we used to measure success, and this is changing, was really with this strict AF-free definition, which is greater than 30 seconds of AFib was considered a recurrence. And what we now know is that patient-centered outcomes are more relevant. The AFib is not going to go away completely. And so instead, what we're doing is thinking about designing our trials to look at what is more relevant to patients, which is symptom relief, quality of life, percentage reduction in AFib burden, rather than these strict definitions. Okay, so we've now covered that early ablation is better for long-term outcomes. And just to help us remember this, we then named a bunch of trials with these exact concepts in mind. So there's so much data. I'm only going to leave you with like 3 quick studies. So one is called Early AF, and that compared ablation versus antiarrhythmic drugs in paroxysmal AF, and it found that ablation reduced the risk of 1-year arrhythmia recurrence by 61% compared to antiarrhythmic drugs. Then there was another trial called Progressive AF. Not surprising what that showed. Early catheter ablation prevents atrial myopathy and delays atrial fibrillation progression. And people treated earlier in their disease course had higher rates of maintenance of sinus rhythm at 3 years. And then there was Stop AF, which showed that ablation significantly reduced antiarrhythmic burden and hospitalizations. So we've talked about ablation. So how safe is this? Because we really want to make sure that if we're sending more and more patients for this procedure, that the risks are low. So over the years, despite a significant change in the profile of the patients, the ablation is actually becoming safer. So we're doing it on older patients, we're doing it on sicker patients, and we're finding that the results, the safety results, are reassuring. And that's primarily driven by all the improvements that electrophysiology has made in the last couple of years. We're using ultrasound-guided vascular access to minimize our vascular complications. There's very low risk of tamponade. We have force sensing catheters now, so we can tell how much force we're exerting when we're moving the catheters. Before this, it was just kind of you did it by touch and feel. And then we're having low risks of stroke and TIA post-procedure because we understand the importance of peri-procedural anticoagulation. All of us will anticoagulate before the procedure for at least uninterrupted anticoagulation for a minimum of 3 weeks. We don't even stop the blood thinner on the day of the procedure. And then we all will anticoagulate for a minimum of 3 months after, just to mitigate this thrombotic risk. And then things like pulmonary vein stenosis are now a thing of the past because we have intracardiac ultrasound, so we can actually see where we're delivering lesions relative to where the pulmonary vein ostium is. All right, so let's spend a little bit of time now talking about what's new. And the next couple of slides are going to go over the 2023 practice guidelines of AFib and just take you through some of the changes. So caffeine consumption. So this is a slide that's really important to me because I think a lot of my patients talk to me about this. So really, there is no recommendation for patients to stop having caffeine if they have atrial fibrillation. And I just want to let that sink in for a second. There is current studies can exclude the possibility of like an individual level idiosyncratic relationship between caffeine and atrial fibrillation. So maybe they feel more PACs, maybe they feel more anxious because it sort of reminds them of that time that they had atrial fibrillation. But randomized clinical trials and observational studies have not shown detectable differences in AFib with caffeine consumption. So drink caffeine in moderation. This one is just the idea of, when you see a patient with atrial fibrillation, there is really no role for this protocolized downstream testing for ischemia, ACS, pulmonary embolus. So people can have atrial fibrillation just based on age alone. It's a disease that is now an epidemic. So unless the patient has signs or symptoms that suggest ischemia or pulmonary embolism, there's really no role for just testing these disorders just because they have AFib. The guidelines in 2023 really stressed on risk factor modification. And to the extent that there's a mnemonic for this called head to toes. And I'll just briefly go over it, but what it stands for is heart failure. And you can see that on the bottom of the slide here, right here. So heart failure, exercise, high blood pressure, diabetes, tobacco, obesity, alcohol, and sleep. And these are the main risk factors. And so that's what we work on in clinic when we meet them. But I think it's valuable to have, primary care, internal medicine kind of reinforce these risk factors to help manage AFib. So let's spend a little bit of time on obesity and atrial fibrillation because this comes up a lot in our clinic. So in short, obesity and AFib are associated. A higher BMI is associated with an increase in AFib burden and disease progression from paroxysmal to permanent AFib. And we'll get into one of the papers that really laid this out for us. So this is a figure from the Legacy trial that sought to evaluate the long-term impact of weight loss and weight fluctuation on rhythm control in obese patients with AFib. So it was a prospective study of risk factor modification in patients with AFib over 4 years. Patients were on antiarrhythmic drug only, so we excluded patients who are getting ablation. And then they categorized weight loss further. So if we look at the top part of this, these are the 3 categories of weight loss. So 3% weight loss, 3 to 9% weight loss, and then greater than 10% weight loss. And then they also looked at one of the common things that we see, which is weight fluctuation. So can they maintain this weight loss? And that's listed here. And so what they found was that weight loss of, here, this is actually up here, if you look at the top part of it, but weight loss of greater than 10% of your body weight resulted in an almost 6-fold decrease in arrhythmia chance compared to those that did not lose that significant amount of weight. And that's a pretty big deal. Compared to all the other strategies that we have for maintaining AFib, weight loss is really an effective way of mitigating your risk. And then what they also saw was that actually you had to try to maintain that weight. So those people that had weight fluctuations or even weight gain, that benefit was actually offset. So how did they lose weight in this paper without using GLP-1s? Because this paper came out in 2015. So they did it the old-fashioned way, diet and exercise. So I think that this is going to change now that we have GLP-1 agonists, and potentially our patients have the opportunity to be able to lose more weight or lose it in an easier fashion. So the recommendations for AFib right now and weight loss, according to the guidelines, is that the ideal target is to at least lose 10% of your body weight to help reduce your individual AF symptom burden and risk of progression to persistent AFib. And then this has been well studied in the bariatric literature. So this is a paper that just shows that bariatric surgery is associated with a substantial reduction in the AFib type. So again, we see on this pie chart, if you look at the orange bar, it's 43% of patients had no AFib after bariatric surgery. And then if you look at the blue colors, like the navy blue, which shows 27%, that basically suggests that 27% of patients went from persistent to paroxysmal. So either their AF went away or they had reverse remodeling and, favorable remodeling and had less AFib or less severe AFib. So what are the recommendations for physical activity? Because I get this question a lot. Can I exercise with AFib? And in patients with, and this was looked at in the active AF trial and some other papers as well, but essentially this was a study that looked at exercise intervention combining home and supervised aerobic exercise over 6 months. And what they found was that there was a greater freedom from arrhythmia recurrence, reduced AF burden, and improved quality of life. And to date, there's little evidence that high-intensity aerobic exercise is clearly favorable over moderate intensity exercise. So maybe moderate is probably just fine. There's some suggestion, though, that extreme levels of exercise have been associated with higher incidence of AFib, especially in men. So extreme is pursuing years of regular, high volume, greater than 3 hours a day in high-intensity endurance training. So it's kind of your more of your athletes than perhaps cardiology residents. And so think of exercise as a J curve. A little bit is good, a moderate amount is good too, too much, maybe not. And then alcohol, I get this question a lot too. So this is clearly stated in the guidelines where if you're looking for a rhythm control strategy, you need to minimize or eliminate alcohol consumption. This makes me very unpopular in clinic. Alcohol abstinence was studied in one of our papers, and one of the papers that came out from California and basically what it looked at was cutting down alcohol and to what degree. And essentially the idea was as close to cessation or abstinence as possible. And then maybe less than 2 drinks a week, less than or equal to 2 drinks a week for those that are not interested in completely stopping drinking. And then sleep apnea, this comes up a lot too. So it's a 2B recommendation to screen for obstructive sleep apnea. So when formal testing for sleep disordered breathing is used, the disease is frequently observed in about 20% of patients with AFib. They have a diagnosis of sleep apnea. So that's just if you look at the kind of large observational studies. Now, the signal from these large observational studies is actually pretty consistent that obstructive sleep apnea is associated with poorer outcomes with atrial fibrillation even after ablation. And so we would recommend that we test patients for sleep apnea. However, it's an association, and the randomized clinical trials have not been adequately powered to reveal a true relationship between the two. So my takeaway from this is, if you see a patient with AFib in your clinic and you're suspicious for sleep apnea, you should test them. They should get treated for their sleep apnea, but their AFib may not go away. Maybe once a year I have a patient where I put them on CPAP and then their AFib kind of seems to have gone away for that year, but that is not the norm. So be prepared to institute strategies for AFib management other than just sleep apnea treatment. And then this comes up in internal medicine a lot. So what about all those patients who come in and have sepsis, pneumonia, UTI, et cetera, and now have a new diagnosis of atrial fibrillation? We anticoagulate them. We, try to get rhythm control with a cardioversion or rate control, send them out. What are their chances of developing AFib later on? And so this graph kind of tells you that in patients who have AFib in the setting of an acute medical illness or non-cardiac surgery, the recurrent AFib rate is approximately 40% during a 5-year follow-up. So those that do trickle into my clinic with AFib during an acute illness, I sort of tell them, we probably need to have some kind of long-term monitoring system in place. And now with the advent of wearables, those are the people that I say you probably want to consider some sort of wearable device because your AFib is likely to come back in 5 years. This is a slide that it may not age well. So in a few years, if you ever look at this talk again, you might need to skip forward through these slides because this is an area that is going to change. But at the moment, we get asked a lot about left atrial appendage occlusion, and that's a whole separate talk in and of itself. But at the moment, the guidelines support left atrial appendage occlusion with Watchman in patients who cannot clearly take anticoagulation. So you have to demonstrate that you have some contraindication to anticoagulation for us to offer a Watchman. I think that's going to change. And then just something to know that there was a lot of literature on left atrial appendage exclusion at the time of cardiac surgery, and our surgeons are fantastic about excluding the left atrial appendage if they're going in for cardiac surgery for something else, because that does decrease your future risk of stroke. At the moment, the current data suggests that if your CHA2DS2-VASc is greater than 2, and that's what's on this slide, you actually probably need to be on anticoagulation anyway, even if your left atrial appendage has been excluded. And that's because there's a risk of non-left atrial appendage strokes as well in these AF patients. That may also change in the future. And then lastly, sometimes you might see AFib being diagnosed on a pacemaker interrogation or a defibrillator interrogation. And so the question is, you see the atrial lead has some AFib-like activity, and when do you anticoagulate? And this has been an area that we've recently looked at in detail with the NOAA and atresia trials, but and these guidelines were actually published before some more data came out. But I think the take home here is we look at their CHA2DS2-VASc score, and then we see how long they've had their AFib for. So if it's AFib less than 5 minutes on a pacemaker, we pretty much won't anticoagulate these patients. But if it's AFib greater than 5 minutes, we'll look at their CHA2DS2-VASc score. Is it 2 or is it 3? And then look at the duration and then probably institute anticoagulation. So there is sort of a recognition that it's not just any AFib, but it's AFib for some duration of time that probably increases your risk, along with some personal risk factors, which is a high CHA2DS2-VASc score. I have to give you a little bit of information on the new kid on the block. So that's electroporation, pulsed field ablation. This is not a new idea to medicine, but it is a new idea for electrophysiology. So the idea of electroporation has been used in basic science research to create reversible pores in cells and allow uptake of DNA, RNA, etc. It's used in cancer therapies. And in electrophysiology, the high voltage electrical pulses creates nanopores in the cell membrane, and that causes irreversible cell death, non-thermal cell death. And then unlike radiofrequency or cryoablation, which is a freezing technique, the good thing about pulse field ablation is it preferentially targets the cardiac myocytes only and spares the surrounding structures like the esophagus, the phrenic nerve, the pulmonary veins. These are all targets that we can collaterally damage when we're doing our AFib ablations with radiofrequency and to some degree with cryo as well. So if we look at the safety and efficacy data, this is just information from the MANIFEST study. We studied, just 17,000 patients with AFib and pulse field ablation. And what we found was that there was a shorter procedure time with pulse field ablation. It's just much quicker. And it's like 30 to 40 minutes versus an RF pulmonary vein ablation might take anywhere from 60 to 90 minutes. And there's reduced collateral damage. And so PFA is shaping up to sort of be a paradigm shift in atrial fibrillation ablation. We've shown that it's non-inferior compared to the other modalities, and it actually has an improved safety profile when compared with cryo and radiofrequency. And I think the vast majority of us now in EP are just doing pulse field ablation as our first line for AFib ablation. And in fact, later this year, there's the hope that we'll have like point-by-point pulse field ablation, so radiofrequency is going to become less and less favorable. And then lastly, I wanted to talk a little bit about wearable smart devices. So how smart are they? So there are a number of consumer-held automated devices. All of them are leveraging AI to automate AF detection. And if you look here, the sensitivity and specificity is pretty good. Can't bring my pointer up again, but if you look at for the Apple Watch, which is the first column in red, the sensitivity is about 85%, the specificity is about 75%. And this was after they excluded inconclusive tracings. So in this paper, they took away the inconclusive tracings, and that was about 200 of them. And then they had the cardiologist interpret those inconclusive tracings, and 196 out of 200 of them, the cardiologists were actually able to give you a diagnosis of whether this is sinus rhythm or AFib. So even the ones that the device determined as inconclusive because its AI algorithm couldn't tell what the rhythm is, the tracing was good enough quality for us to eyeball and look at and say, yeah, we know what the rhythm is. So then there was like a Smart Wars study, which kind of provided this interesting idea of like, should we have this hybrid approach where the patient only sends us the inconclusive tracings and we review those because we know that the sensitivity and specificity is good enough for us to say that if it says normal rhythm, it's probably normal rhythm. To some extent, that's kind of how we operate in EP. It depends why we have the monitoring system in the first place. If the monitoring system is there because every time we do a monitor on you, like a 2-week monitor, you never have AFib, but yet you're complaining of palpitations, then I tell those patients, well, consider purchasing one of these devices. And if it shows an elevated heart rate or an abnormal tracing, anything beyond normal rhythm, please send it to me and I'll take a look at it. And sometimes it's just a supraventricular ectopy or PVCs, but it's almost always if the tracing was obtained correctly, meaning, without too much tremor artifact, you can almost always tell what that rhythm is. I think that's my last slide. Yeah, it is. Great, thank you.
Thank you, Dr. Rajab Ali. You covered an incredible amount of material efficiently, which is a delight because I am sure that we have lots of questions on what is a really common topic. So I'll watch online and any here in the room.
Hi, thanks so much. I was noticing like the 2020 article, which is when I came up, and it's so nice that things have proceeded since then, and to get that information today. I'm wondering about how your office is talking to patients about diet and exercise and weight loss in a way, like, do you have any tools that we don't have?
No. In fact, I think your tools are probably better because, we don't prescribe GLP-1 agonists, but you guys do. So I sort of tell them, rely on your primary care for resources. And also, I think this stuff, you're seeing them for an annual checkup. Maybe they don't even have AFib at that point, right? And so these are the things you're looking at. You're looking at the head to toes anyway. Diabetes, hypertension. You're like, okay, you're overweight. What is your cholesterol? Lose weight. So you're already implementing these things, and hopefully what they're hearing from us is just look at the data. It's really going to make a difference for this problem that you now have, your AFib. So no, I don't think we have any additional tools. I will say that the legacy trial, it came out from Australia, and they had a whole, setup to deal with this, like really diet, exercise, constant phone calls, counseling, coaching, exactly. And we just don't have that at the moment. Yes. Yeah, especially when we know their effects are pleiotropic, right? So it's not just weight loss, it's all the other benefits that you get with a GLP-1, but maybe soon.
If GLP-1s are covered in MASL, QI project, so maybe we'll all be working.
Tell me a little bit more about that. Sorry, I'm not familiar with this. Okay. Now tell me about your QI project.
Say for the audience.
Yeah, so my QI project is going to be based around screening patients for MASLD and seeing if we can do like early intervention. One of the things we're thinking about is to see if GLP-1s have like an indication specifically for MASLD if they don't have diabetes.
Okay.
Yeah.
That should be fun.
And I suspect stay tuned for the AFib trials, no doubt, coming down the pipe.
Thank you so much for this talk. I have sort of two related questions. The first one is, is your group going to be have enough manpower to take on all these patients who have AFib for possible ablation? And then the other part is sort of like the logistics of like how you would actually make that referral.
Yeah, it's a great question. So
because sometimes it's like, is it to general cards first and then EP, or if you do straight to EP?
I do think that referring to general cards first is important because they do just so we collaborate with them. They do such a fantastic job of risk factor modification, further screening and workup. Like, is this really lone AFib, or does the person have undiagnosed coronary artery disease? They're morbidly obese, they have prediabetes, that blood pressure is kind of elevated. So they really do such a great job of sort of giving us an idea of what is this person's substrate. And then when we see them in clinic, we have a better sense of, I don't know if this person's going to maintain sinus rhythm long term. They haven't really done the lifestyle modifications, or perhaps they need to go to early ablation and then need an antiarrhythmic later on. But it helps me shape that shape who they are and what their prognosis might be, because general cardiology just does such a great job of doing the initial workup and counseling. In terms of manpower, yeah, we're a pretty large group of EPs actually. So I don't suspect that the bottleneck is going to be the lack of EPs or the lack of lab space right now. I think our biggest sort of plug and takeaway is, with all of this data, and we too are learning, and this is all new information that's come out in the last 10, 15 years, is, we really need to get these patients in earlier. So the long-standing persistent AFib for several years, we're all like, oh, I don't know if this is going to work. But the shorter episodes, paroxysmal, early persistent, they benefit. So I wouldn't say that their disease is progressing because they're waiting for an AFib ablation.
Thanks so much. I think some people in this room were scarred by a horrible case, and we should not practice by anecdote. But a young person who got an atrial esophageal fistula. So I'm just curious if these new techniques are making that less of a dreaded outcome.
Yeah, we're equally scarred by that. That's kind of a very rare complication that you just hope you don't see in your clinical practice. But if you do enough, you probably will. It's like over 1 in 10,000. It's really rare. The nice thing is pulse field ablation is esophageal sparing. And so I can speak for myself. That's one of the reasons that I switched to pulse field ablation because the safety profile is a little bit better. The efficacy is about the same. The problem here with EP at the moment with endocardial ablation is we don't have a great way of getting transmural thickness of our lesions, and lesion durability is our problem. So these pulmonary veins will reconnect over some time. And that's where we need to get a little bit better. So I can't tell you that clearly PFA is clearly superior, but we're headed in that direction. So yes, you will not be seeing, hopefully, atrial fistula with PFA or phrenic nerve palsy, which is also quite dramatic and life-limiting.
Great. We have a question online wondering if there has been an increased burden in atrial fibrillation since the advent of COVID and COVID infections.
I'm trying to think how to answer that. The only way I'd answer that would be probably anecdotally, because I'm not aware of if we've done I'm not aware of any papers that have looked at that specifically. I don't anecdotally feel like I'm seeing a surge post-COVID of atrial fibrillation. I think I'm sort of seeing the same amount of patients that I always see. There wasn't like this huge floodgate of patients coming in with AFib post-COVID.
I have one more question. So, based on the data that you presented, we frequently, in internal medicine see like the triggered AFibs, like they come in for sepsis, pneumonia, whatever. And would you be a fan of like we need to get them back into sinus during the hospitalization, or is this like, oh, we can just treat their rate and see if it goes away?
Yeah, I think acutely you have to we understand that it's kind of like AFib is like a bystander, right? So it's caused by whatever else is going on. And so acutely you have to treat that problem, because even if you brought them in day one, cardioverted them, and they have this terrible pneumonia or, gram-negative bacteremia or whatever it is, they're just going to go back into AFib by day 3, day 4 of hospitalization. So I think you treat the underlying cause, but then I would recommend prior to discharge thinking about how you're going to get them back in normal rhythm. If they're well, or you need to have like short order follow-up, because what we don't want is to sort of have that patient be in AFib for several months. And a lot of these patients, we think that this is a new diagnosis right now, but because it's a discovery of a problem that is new to the patient, but they could have had AFib even before they got sick. And so actually they're not new AFib, short episode kind of a person. They might actually be somebody who's early persistent now or becoming more into the permanent range. And we just found out about this when they were admitted.
I might ask a follow-up question to that. Yeah, I think we do see very commonly in internal medicine also where we are discovering AFib, and almost certainly we assume that it is not new, and specifically not newer than a year. Often these people have LA dilation, they're probably in permanent AFib. Can you give us any more guidance about who among this vastly large population of patients should be benefited, should be referred, and exactly, any guidance, because there's a lot of these people.
Yeah, there's some of them are symptomatic, some of them are asymptomatic. I'm assuming, asymptomatic because they didn't know they had AFib and you diagnosed it. And really the thought is everyone deserves a trial of sinus rhythm once. So each patient, I would kind of individually think about them and say, look, let's try to get you in normal rhythm. And then decide whether long term that makes sense or not is sort of up for debate. But for every patient, even the asymptomatic patients, we try a trial of normal rhythm. And that's because the patient does not know, and nor do we at that time when we meet them, whether they're truly asymptomatic. And there's so many patients that we will see in this situation where we'll put them on a medication or cardiovert them, and they'll tell you, and there's actually, I didn't present those papers today, but there's 3 papers that I was looking at last night that talk exactly about this, which is asymptomatic AFib. And in the week post-cardioversion that they maintain normal rhythm, the biggest changes that patients report are 2. Changes in respiration, which in that paper means I can breathe better, And then the second thing is decrease in fatigue. So those are the two main symptoms. So those are pretty subtle symptoms, right? Like when you meet them, they're like, oh, I don't know. I mean, I'm not sure. I'm just like more tired because I'm older. But if you dig a little deeper and give them that trial of normal rhythm, they can tell you there's a difference that's almost like night and day.
For all the repeat askers, this is great. It's just stimulating all these questions for us. So especially for the sake of our residents, you mentioned sort of the triggered AFib that they see a lot of. You know, patient comes in with sepsis, and maybe their AFib gets better, you hope, before discharge. But presumably they have not been anticoagulated. So if they're not particularly symptomatic or hypotensive or heart failure, presumably we don't want to actually try to get them into sinus rhythm. And, you know, we'd rather anticoagulate them and see them in 3 weeks.
Yeah, that's fine too. That's fine too. As long as you're seeing them in 3 weeks, that's completely fine. Yeah.
This is a great talk. I really appreciate it. From the hospitalist perspective, we're often seeing these patients at their index hospitalization when they come in with new AFib with RVR, and you know the ED starts some rate control, and then we bring them into the hospital. Presuming that they don't spontaneously convert on their own, should we really be now trying to get everyone to TE cardioversion during that hospitalization? Because I always fear, you know, trying to get people seen within 3 weeks who may not even have a primary care doctor at that stage. It's really just don't know. Like I may get them rate controlled, but I don't know how quickly they're going to get in to see somebody. And compelling data that the sooner we try to at least get them that opportunity to be in sinus rhythm, they'll probably have a better outcome down the road. So we're already always left like, do we reach out to cardiology now?
Yeah.
And or is this something they're going to be like, oh, another hospitalist reaching out with an AFib patient? And so, you know, I'm just trying to like how
bread
quickly.
and butter of what we do.
Yeah.
So don't feel bad. But I think the question is, where do you want the bottleneck to occur, right? That's so unfortunate. Like in the hospital where we have a bunch of people that need T cardioversion, or in clinic where a vast majority of these people will convert in 3 weeks. So I don't know that it makes sense to necessarily just say we must get you back in normal rhythm on this index admission. What would be sort of more ideal is that they have close follow-up. So some of it will fall to primary care, some of it will fall to our kind of our general cardiology colleagues who will see the consult and then, you know, try to get them in to see them in clinic, to maybe share, and some of them to EP, you know, we see them, and especially if this is not their first AF episode and they've been having this for a while and clearly need an antiarrhythmic. And so we can hopefully share some of that workload so that it's not all, you know, primary care has to deal with that 3 weeks later. But I think that some of these patients will convert. And so I don't know that I would necessarily be so strict about saying they must be in sinus rhythm on the day of discharge if they have a plan. And they're rate controlled. They got to be rate controlled.
Sort of to that point, value of a CT of the left atrial appendage, in case you can't, not capacity to do a TE, does that make you feel better enough to convert somebody?
Yes, so we do CT, we order a lot of CTs in EP. We pretty much don't do as much TE anymore. For our like outpatient ablation cases, for example. And there's two reasons for that. One is when I order a CT, I can look at the pulmonary vein anatomy, but then that same CT protocol will also look at the left atrial appendage and tell me if there's any thrombus. So like high risk people who are coming in for ablation, CHADS VASC 4, 5, 6, you know, I know they're going to present an AFib on the day of ablation. They have a CT like 1 or 2 days before that reassures me that their left atrial appendage has no clot. We do a lot of inpatient CTs too, especially if, you know, we think we're going to start an antiarrhythmic, for example. So then sending them to TEE is just a lot of logistics. There's also risks with another procedure. There's radiation with CT too, but if their kidney function is normal and we can do a left atrial appendage CT, we will do that. And that is good enough.
So if I'm feeling worried that somebody's gonna become unstable, get the CT, and then in the next day or two, if they do, we feel good about.
Yeah, and you can use
staffing
amiodarone.
them, or-
You can use IV amiodarone
Cool.
if you're like, this person's unstable.
Great. I'll ask one more outpatient referral question. It's really helpful from the primary care side to know what patients might expect or happen when they see a specialist. Just curious, and this is a really broad question, but how often are patients being offered an antiarrhythmic drug versus a procedure, and factors that may influence that going one way versus the other?
Yeah, that's a great question. The recent guidelines actually updated ablation as first line to class 1 indication. Before this, it was sort of like try an antiarrhythmic, fail an antiarrhythmic, and now you can just, because the safety profile is so good, you can just offer that as either or. Now I'll tell you realistically what happens is it does take us about 2 months to get a patient in for a catheter ablation. So if they're seeing us, they've already seen primary care and general cardiology, they're probably pretty symptomatic. And so we will put them, usually we will offer them an antiarrhythmic if we think that they're going to have significant amount of episodes in the next 2 months waiting for an AFib ablation. But if it's like, okay, they have AFib pretty, once every 3 months or so forth, then you could sort of hedge and say, maybe not worth starting the antiarrhythmic now when we think that post-ablation, you probably do well and not even need it.
Great, thank you. I'm going to pull a question from online. I don't have the context for why a 2-week monitor has been done. However, it shows combined paroxysmal AFib and short runs of tachycardia. I guess a little unclear, presumably maybe short runs of VTAC also. So I think this person is curious, any particular rhythm strategy for that patient, maybe incidentally found perhaps on an outpatient monitor to have paroxysmal AFib and short runs of VTAC.
Yeah, they need to be seen by cardiology and EP. Usually what we'll do is we'll get an echocardiogram, and this is kind of where understanding the entire patient and not just their AFib is important. So do an echo, make sure they have a structurally normal heart. Maybe they need, you have to meet them and talk to them about their symptoms, but they might need ischemia workup and so forth. And then maybe that short episode of VT is just brief episodes of non-sustained ventricular tachycardia. You can just treat with a beta blocker, or maybe it's a harbinger of something else, that they've got underlying coronary disease or their EF is low on the echo. So it just changes the picture. And I think that's where collaboration with everybody is so helpful, because if you just come into clinic, it's like, well, I don't know, I see exactly what you see, AFib and non-sustained VT, but I'm not sure what to do about it until I have more information, which primary care and cardiology is just so great about getting for you, so that when you see the patient, you can just answer the actual question of how relevant is this VT and what do we do about their AFib.
Well, fantastic. Thank you, Dr. Odabali, for leaving us with so much time for so many questions. This is ideal. We are coming up on 9 o'clock. Really appreciate your teaching.
Thank you. Thanks for having me.